Welcome to this video. In this video we're going to talk about diseases of the kidneys. Now in this video we're not going to go over the basic anatomy and physiology of the kidneys. If you would like to revise that basic knowledge, I refer you to my video entitled The RAS and ADH Systems. In that video we firstly go over the basic anatomy and physiology of the kidneys, and then we discuss those two vital homeostatic systems that centre around the kidneys, namely the renin-angiotensin-aldosterone system and the antidiuretic hormone system. So in this video we're not going to recap that basic anatomy and physiology, so if you do want to go over that first, please go to that video. So, kidney disease then. To begin with, the way I want to organise this is I want to talk to you about the four major categories of kidney disease, the four major presentations of kidney disease, the four major ways in which the kidneys can be damaged and lead to a certain type of presentation. And you'll understand what I mean by this more once I've actually told you about these four categories. Then what we'll go on to is discussing different causes of each of these four categories of disease. So let's firstly write down the four different categories of kidney disease, and then we'll discuss what each of them entails. So, number one category is acute kidney injury, or AKI for short. This used to also be called acute renal failure. So I'll also put ARF there for acute renal failure. We dropped this name of acute renal failure because renal failure scares people. If you tell a patient that they've got renal failure, that sounds very, very bad and it scares patients. So we've dropped this name of acute renal failure and we now call it acute kidney injury, or even better, we just refer to it as an AKI. Then the patient doesn't know what we're talking about at all. So that's category number one, and as I say, I'm going to write down all the categories and then come back to actually explaining what they entail. Category number two is CKD, which stands for chronic kidney disease, and again this used to have an old name which was chronic renal failure, so again I'll write that down there, CRF for chronic renal failure. Again we dropped the renal failure because that sounds scary. So acute kidney injury and CKD, those are two major categories of kidney disease, but there are two other ones that I want to add on here. The third one is nephrotic syndrome, and I'll write this out in full. So nephrotic syndrome. And the fourth one is one that you would never give as an actual diagnosis, but regardless, I think it's a very important one to write down to help people organise their ideas about kidney disease. You'd never give this final one as a diagnosis, but it is regardless useful when thinking about kidney disease and organising your thoughts. And by the way, from now on, I'm going to refer to nephrotic syndrome when I write it down just as NS for short. So the fourth one that I'm going to put here is an unofficial one. It's an informal one, but it's one that I find very, very useful when organising my thoughts of what's happening. And this is renal hypoperfusion. So perfusion means blood supply. Hypo means too little blood supply. So this is where there's too little blood supply coming to the kidney. And this has a certain clinical presentation. It has a clinical phenotype. And although, as I say, you'd never actually give this as a diagnosis of someone's kidney disease, I think it's a very helpful thing to think about when you're thinking about kidney disease, and we'll refer to renal hypoperfusion just as RH. Now, before we go any further, some of you, if you know something about kidney disease, might have been expecting me to write down something different here. Rather than writing down renal hypoperfusion, you might have been expecting the fourth one to have been nephritic syndrome. So this is an old way of thinking, where there was nephrotic syndrome and nephritic syndrome, and I'll just write down nephritic to contrast it to nephrotic. And I'll talk a little bit more once we've actually talked about what each of these categories entails, about what nephritic syndrome was, and why it's not really that useful a category to have. So I will be referring to nephritic syndrome at several points throughout the video on kidney disease, but I'll be referring to it simply to explain to you when you could actually use this term. However, I would advise you to avoid this term. It's not particularly clinically useful. We very rarely, in fact, I've never seen someone given the diagnosis of nephritic syndrome, and I don't really think that it's that actually helpful in understanding and categorizing kidney disease. So I am not having this as a category of kidney disease. However, I will be referring to it throughout the video just so that you know when it would have been appropriate to previously use the term nephritic syndrome. But I would advise you to steer clear of it. It's not a useful categorization. So let's now talk then about what each of these categories entails. What do I mean by each of these 4 categories? And the 4 categories are the ones in blue. Ignore this one down here. So acute kidney injury. What is an acute kidney injury? So an acute kidney injury or acute renal failure is where, for some reason, lots of the nephrons in your kidneys have either stopped working or their function has been reduced. And it may well be that every single nephron in your 2 kidneys has suffered a functional decline. However, as part of the definition of acute kidney injury, it means that lots of the nephrons, at least a huge fraction of them, have for some reason hugely reduced their function. So the amount of urine that they are producing, the amount of glomerular filtrate that is being produced from the blood and is moving through the nephron, and then a tiny fraction of that becomes urine, the amount of that is occurring, and therefore excretion of waste products that is occurring through that nephron, has for some reason gone down. That is what an acute kidney injury is. And it is an acute thing. So it may well be that these nephrons whose function has decreased temporarily, transiently, they may be able to completely recover and regain their original function. So it does not mean that the kidneys have been permanently damaged. It is an acute phenomenon that for some reason, at present, a huge fraction of your nephrons have suddenly either stopped working completely or their function has been hugely reduced. But the key thing that separates it from this one over here is that this loss of function may well be reversible. If it's not reversible, then it will become this type of presentation over here. But if the loss of function is temporary and is reversible and the kidney can get better, that's what characterizes an acute renal failure or an acute kidney injury. Now, let's think about what this is actually going to result in for the patient who suffers this transient loss of renal function. Well, we have to think about what is the function of the kidneys. So the kidneys have a multitude of functions, but one of the main things is that they function to get rid of metabolic waste products that we excrete into the urine. If there has been a huge drop in kidney performance, in kidney function, which is the definition of what an acute kidney injury is, then those waste products aren't going to be excreted properly and are going to start building up in the blood. And we have a name for this when waste products start building up in the blood. We call it uremia. So this is one of the features of an acute kidney injury, that waste products within the blood are going to start building up. And clinically, the 2 waste products that we measure are urea and creatinine. There are loads of other ones, but those are the ones that we measure to gain an idea of how well the kidneys are currently functioning. So I'll just write these down here. So we have urea, which we abbreviate to UR, and creatinine, which we abbreviate to CR. And the usual ranges for these are urea should be between 2.5 and 7.5 millimolar, and creatinine should be between 50 and 120 micromolar. So in uremia, what's going to happen is urea is going to go above this upper threshold here, and creatinine is going to go above this upper threshold here. And those are the clinical representatives of all of the different waste products that are in the blood that are excreted through the kidneys. And if they're going up, the thought is that all the other ones are going up as well. And the buildup of waste products in the body, what can this result in? Well, it can result in loads of different organs around the body starting to misfunction. In particular, this can have a big effect on your mental status. It can cause you to go into a confused or drowsy mental status. So it can alter your level of consciousness, basically, when waste products within the blood build up. It can also, if it gets extremely bad, potentially affect organs like the heart and potentially lead to cardiac arrhythmias and, in worst case scenario, cardiac arrest. So it can be very, very dangerous. Another classic symptom of uremia is when the waste products build up in the skin. This can cause the desire to itch, so it can lead to pruritus, which is the fancy name for itchiness of the skin, and that will be widespread over the entire body. But uremia, to be honest, it's not really a clinical diagnosis. You cannot really, with any certainty, say that someone is uremic just by taking a clinical history. Really, it's a diagnosis that is made by doing blood tests, and nearly everyone who comes into hospital is going to have their kidney function measured, where we're going to measure their urea and creatinine level, and if those are raised, then we can make the diagnosis of uremia and potentially acute kidney injury if this is an acute uremia. So uremia is one of the results of AKI. More results, however, the kidneys do more than just excreting metabolic waste products. Potassium is another key thing that you have to think about when the kidneys aren't functioning correctly. So we eat a huge amount of potassium every day, and it's very, very important that the level of potassium in the extracellular fluid remains constant. So in order to do that, in order to maintain an equilibrium, what has to happen is potassium has to be excreted by the kidneys into the urine, and indeed the same amount of potassium that is eaten each day, consumed each day, needs to be excreted by the kidneys. If kidney function is reduced, so if glomerular filtration rate has gone down because a huge number of nephrons are now not functioning to the level that they should be because we're having an AKI, that potassium isn't going to be excreted properly, so it will build up in the extracellular fluid, so you can become hyperkalemic. So I'll put this here. This is another problem with AKI, that potassium level can go up. So you can get hyperkalemia. And the normal range for potassium within the blood is 3.5 to 5 millimolar. And often this will be something that we measure when we measure urea and creatinine. Indeed, we often, in Britain at least, we do a blood test that is called UNEs, which stands for urea and electrolytes. And this includes urea and creatinine to look for uremia, and then it also includes the two electrolytes, potassium and sodium. It allows us to assess how badly someone is in an acute kidney injury very well, because we get the waste products here and we also get to look at their potassium. So in hyperkalemia, the potassium can go over 5 millimolar. And this is quite dangerous because it can most definitely lead to cardiac arrhythmias and potentially cardiac arrest. So we get worried about hyperkalemia. So that's a very serious consequence of an acute kidney injury. What else do the kidneys do? So the kidneys are also involved in maintaining acid-base balance. So again, all of our tissues around our body are metabolically active, and we've discussed that they produce waste products from their metabolic activity, and urea and creatinine are two examples of these. But they also often produce protons as a waste product, and therefore the extracellular fluid is gradually going to become more and more and more acidic unless we get rid of these protons. And the way in which we get rid of these protons is through the kidneys. So if kidney function goes down, we're going to have less ability to get rid of these protons that are being produced metabolically, and therefore we can result in an acidosis. And this would be called a metabolic acidosis because the protons are being produced by metabolic activity, in contrast to a respiratory acidosis, which has to do with problems with getting rid of the carbon dioxide that is being produced by tissues all over the body. And that's, of course, on the respiratory system to get that done. So if the respiratory system is failing, if someone's in respiratory failure, carbon dioxide can build up in the blood, and that can also lead to protons building up in the blood. But in that case, it's because of too much carbon dioxide rather than because the protons have been produced by metabolic activity. So that would be called a respiratory acidosis. So in contrast, this is a metabolic acidosis. So it can also result in a metabolic acidosis. And since I've been giving you lots of these figures, let me also give you the normal range for pH within the blood. So it should be between 7.35 and 7.45. So in an acidosis, remember the pH goes too low because this is the negative log of proton concentration. So as proton concentration goes up, this number actually gets smaller. So metabolic acidosis is another serious consequence of an acute kidney injury. And again, all of these things, they're not really clinical diagnoses. These are diagnoses that you would need to do blood tests for. And to diagnose a metabolic acidosis, we would generally do an arterial blood gas test, an ABG, which can measure the proton concentration within the bloodstream. So I'll just put this here. We can do an ABG to do that. So this stands for an arterial blood gas. So this actually is a blood test that you need arterial blood to do if you want to measure the pH in the arterial blood. You could take a venous sample, but that would give you the pH in the venous blood, which is always going to be slightly lower than in arterial blood because it's got a higher concentration of carbon dioxide within it. So often, to assess pH, you'd want to do an arterial blood test. The problem is patients don't like having arterial blood tests because it hurts hugely putting a needle into an artery, a lot more than it hurts putting a needle into a vein. However, that's another very serious consequence. And again, if proton concentration in the extracellular fluid goes off, this can have major consequences all over the body, for tissues all over the body. They're all going to start misfunctioning. So again, looking at the brain, it can result in altered mental status, which is the brain not functioning correctly. Looking at the heart, it can result in cardiac arrhythmias potentially, and maybe worst case scenario, cardiac arrest. So all of these metabolic derangements, they're very, very dangerous. They're not really clinical diagnoses, they are diagnoses that are made through blood tests. The final thing that I want to put on here as a result of an acute kidney injury is fluid overload. So of course, the other thing that the kidneys are involved in balancing is how much fluid your body has. We are continuously consuming fluid every day. We drink fluid, we're adding more fluid into our extracellular fluid volume. In order to maintain an equilibrium so that we don't just swell up, the kidneys have to excrete the same amount of fluid. If kidney function has gone down, then that fluid can build up, so you can potentially become fluid overloaded. Where does the fluid go? Well, initially it's going to be in the blood vessels, of course, but the blood vessels can't hold indefinite amounts of fluid, so eventually the fluid will start leaving the blood vessels and going into the peripheral tissues and causing peripheral edema. Classically, the edema will end up in the legs just because of gravity pulling it down there. That's the more likely area for the fluid to come out of the blood vessels. So you'll classically end up with swollen legs that will pit when you press on them. So fluid overload can be another manifestation of AKI. However, be aware that for fluid overload to occur, it's not just enough to have an acute kidney injury. You also have to consume the fluid that is going to overload you. So if you've got an acute kidney injury and you drink too much, then you will become fluid overloaded. If you were to get an acute kidney injury but you didn't actually drink that much, of course you're not then going to become fluid overloaded, because if you're cutting down the consumption of fluid, it doesn't matter that your excretion of fluid has gone down. You're not going to become fluid overloaded in that case. You can balance the equilibrium basically. So it is important to be aware that there are two factors that need to be working together to produce fluid overload. Problems with excretion, but also too much consumption in the face of that reduced excretion. So those are the major manifestations then of an acute kidney injury: uremia, hyperkalemia, metabolic acidosis, and fluid overload. Fluid overload is the only one that you can actually diagnose clinically just by looking at the patient and talking to the patient. The others, you need to do blood tests to diagnose those. No matter how clever you are, you're not going to be able to, well, maybe some people can, but really you need to do a blood test to confirm these. Right, let's now go on to our second category, CKD, or chronic renal failure. This is where kidney function is reduced and it is permanently reduced. It's never going to come back. In this case, you have lost nephrons permanently. Nephrons have been damaged beyond repair and they may well have been dismantled and replaced with scar tissue. So in chronic kidney disease, the number of functional nephrons that are left in your two kidneys is reduced from what it should be. And that is because some sort of disease process has led to the nephrons being damaged, them effectively dying and then being replaced by scar tissue. So that is what the difference between acute kidney injury and CKD is. In acute kidney injury, your nephrons are still there, but for some reason they're not functioning up to scratch. They're not functioning as well as they should be, but this loss of function may well be temporary. In CKD, they have been permanently lost. They are now permanently non-functional, and you have a reduced number of functional nephrons left. So that means that your kidney function is permanently reduced long term. Now, what are the manifestations of that? Well, they are all the same as the manifestations that we have here, but I want to add some additional ones on as well. So you're still going to get problems potentially with uremia, in this case chronic uremia. Your waste products in your blood are going to be chronically elevated. You're still going to have problems potentially with hyperkalemia. Your potassium is going to maybe be bordering on the higher level, and you're going to maybe have to reduce the amount of potassium that you consume in your diet to balance this. You still may face problems with metabolic acidosis, and you still may face problems with fluid overload. All of these are features of chronic kidney disease. The difference is that in acute kidney injury, they were an acute problem, and once your kidney function went back up to scratch, they would go away. In chronic kidney disease, these are going to be with you for the rest of your life, and they're going to have to be things that you manage. As I say, you can attempt to manage them. You can avoid potassium in your diet, avoid bananas, and you can also manage the amount of fluid that you're taking. You can restrict the amount of fluid that you're taking on a daily basis to try and avoid yourself becoming fluid overloaded. However, there are two additional problems that people with chronic kidney disease face that people with acute kidney injury don't face. And these are the anemia of CKD, ACKD as I'm going to call this. So if you remember your physiology of the kidneys very well, you will remember that the kidneys are actually the site of erythropoietin production. So I'll just make a little bit more space here. So the kidneys are where erythropoietin, and I hope I can spell this correctly. I think this is how you spell it. Erythropoietin is produced. EPO for short. And this is the hormone, the signaling molecule that goes into the blood and goes to the bone marrow and tells the bone marrow to produce red blood cells. And remember, the kidneys are deciding how much erythropoietin to release based on how many red blood cells and how good the oxygen supply to them is. So remember, this is a function of the kidneys that is completely separate to their function of producing urine and excreting waste products. This is another separate function of them. That they are in charge of looking at how many red blood cells are in the bloodstream, and they do this by looking at how good oxygen delivery is to the kidneys, and then they decide, based on that, how much erythropoietin needs to be produced, and the erythropoietin signals to the bone marrow how many new red blood cells to produce. So, if you have permanently lost nephrons and they have been replaced by scar tissue, oh, by the way, it is the cells of the nephrons that do this. That's important to know. It's not interstitial cells of the kidneys, it's the cells of the actual nephrons. So if you've lost nephrons, then you're going to get reduced erythropoietin production, and if you get reduced erythropoietin production, you're going to get reduced red blood cell production. So gradually your level of red blood cells in your bloodstream is going to go down. This is going to make you anemic. Anemic is the name for reduced hemoglobin concentration within the bloodstream, which corresponds usually to reduced red blood cells within the bloodstream. So you get anemia, and that anemia is called the anemia of chronic kidney disease, ACKD for short. And for those of you who know something about anemia, you will know that anemia is divided into microcytic, normocytic, and macrocytic. Anemia of chronic kidney disease is a normocytic anemia, and what that means is that the size of the red blood cells is normal in this type of anemia. It's just that the number of them is reduced. In microcytic anemia, you have reduced numbers of red blood cells and the size of them is reduced. In macrocytic anemia, you have reduced number of red blood cells, but the size of them for some reason has increased. So in this anemia, of course, it makes complete sense. You're just signaling to the bone marrow to produce less red blood cells. This isn't going to change the size of the red blood cells, it's just going to change the number of them, and therefore it makes sense that this is going to be a normocytic anemia. This is only a feature of chronic kidney disease because when you've just got an acute reduction in kidney function, that's not enough time to actually see any difference in the number of red blood cells. Remember, red blood cells live for 120 days. So to actually see a problem with red blood cell numbers in your bloodstream due to loss of kidney function and loss of erythropoietin production, you have to have had it for a long period of time to actually give time for the red blood cells that you already had prior to the kidney disease to have been used up and you to be in need of the ones that should have been produced from the erythropoietin that the kidneys were producing. So that's why it's only a feature of chronic kidney disease, not a feature of acute kidney disease, because acute kidney disease quite simply does not last long enough to cause this. Right, so that's one of the additional manifestations of CKD, in addition to the manifestations of AKI. Another one is vitamin D problems. So again, if you are good at renal physiology, you will remember that the kidneys also have another role that is separate to their production of urine, which is the activation of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D, which is the active form. And remember that the active form of vitamin D is needed to absorb calcium from the gastrointestinal tract lumen. So if you have problems with producing the active form of vitamin D because you've permanently lost kidney nephrons, and again it's the renal tubule cells that are responsible for the activation of vitamin D, then you're going to gradually lower the calcium level in your blood. How does the body respond to that? Well, it takes the calcium out of the bones, and that gradually weakens your bones, makes holes in your bones. So you get what we call renal bone disease, RBD for short. There is another name for this that is very fancy, which is renal osteodystrophy. And it is effectively a weakening of your bone tissue, potentially even osteoporosis of your bone tissue because of your chronic kidney disease. And as I say, it's caused by problems with activating vitamin D, and activated vitamin D is essential for absorbing calcium from the gastrointestinal tract. So just to add a little bit more onto this, let me just remind you of the basic physiology of vitamin D. So we make vitamin D, which I'll just abbreviate to VD, in the skin, of course. It then needs to go to the liver to be activated into the first form, which is 25-hydroxy vitamin D. So this is done in the liver, this activation. The production of the initial thing is done in the skin, and of course everyone knows that you need ultraviolet radiation to make vitamin D from cholesterol in the skin, so that's why we do all need to go outside once in a while to top up our vitamin D levels. But the vitamin D that we produce in the skin is not actually the active form yet. It then has to go to the liver and be activated into 25-hydroxyvitamin D, and still it is not yet in the active form. It has to then go to the kidneys, bizarrely, of all places, to be activated into 1,25-dihydroxyvitamin D. And then this is the form that can actually then go to the gastrointestinal tract and tell it, absorb calcium, we need some calcium. So if you've got permanent loss of kidney function, loads of nephrons have stopped functioning, then the activation of vitamin D is going to be hugely reduced. The levels of this active vitamin D in the bloodstream are going to be reduced, and therefore you're going to end up with less calcium being absorbed by the gastrointestinal tract, and that calcium has to be replaced into the extracellular fluid, so it comes from the bones. So you gradually get a weakening of the bones, potentially osteoporosis. We call this renal bone disease or renal osteodystrophy. And again, this is a manifestation that you have to have kidney disease chronically for to actually get, because it takes a long time to actually remove enough calcium from the bones that they're actually weakening. It's not going to be something that happens just with an acute kidney injury. Next, let's go down to our two categories down here, nephrotic syndrome and renal hypoperfusion, and hopefully these are going to be slightly quicker discussions than AKI and CKD were. And let's get another colour. Where should we go to next? Let's have an aquamarine colour. So nephrotic syndrome. Nephrotic syndrome is a classical syndrome that medical students should know about. This is where the renal basement membrane has been damaged and now allows proteins from the blood to be filtered into the glomerular filtrate. So I said I wasn't going to go over basic renal physiology, however I am just going to draw a picture of a renal corpuscle here. So here is the Bowman's capsule and the beginning of the renal tubule of the nephron. And here then now is the glomerulus, which remember is this collection of capillaries. So there's the afferent arteriole, efferent arteriole, and then remember we have a collection of capillaries here that are in this space. And unfortunately I've made the pen a little bit too thick that it's now making it look a little bit cluttered. There, that's a better thickness to have. Okay, but I'm sure you know your basic renal structure. So this is our, whoops, let me undo that. This is the Bowman's capsule here. This is the glomerulus, afferent arteriole, efferent arteriole. So you have this collection of capillaries here that are in this bowl or part of the Bowman's capsule. And of course, blood is coming through here, and there is a membrane between the lumen of the capillary and the lumen of the Bowman's capsule, and across that membrane is where the ultrafiltrate is produced to produce this glomerular filtrate. And usually, proteins cannot cross this membrane. And remember, this membrane consists of the endothelial cells of the capillaries sat on a basement membrane, which is connective tissue, and then on the other side you have the podocytes of the Bowman's capsule. So that's what makes up this glomerular basement membrane. Now, in nephrotic syndrome, and we'll come on to the things that can cause this, the different diseases that can cause this, but in nephrotic syndrome, for some reason, the glomerular basement membrane, which we usually abbreviate down to GBM for short, has been damaged. And this means that proteins, it's been damaged in such a way that now proteins from the bloodstream that could not previously exit the bloodstream and go into the Bowman's capsule can do. And can I just make a correction to what I said previously? I previously think I said that no proteins can cross the glomerular basement membrane usually. That's not quite true. Small proteins can. Indeed, many small proteins, insulin being a notable example, do actually cross the glomerular basement membrane and do go into the glomerular filtrate, and they're actually broken down then by the renal tubular cells. That's the way that insulin and many other small protein hormones are actually broken down by the kidneys through being filtered by the glomerular basement membrane. So that was incorrect when I said no proteins can. Small proteins can. However, big proteins, in particular, the one that we pay attention to is albumin, a really important protein within the bloodstream. Just to illustrate how important it is, there is 35 to 50 grams of albumin in every litre of blood. That's the usual concentration of albumin within the bloodstream. So albumin is a massive great protein produced by the liver, put into the bloodstream, and which many different things bind to in order to be transported around the bloodstream, notably free fatty acids that are released by adipocytes of the body. They are bound to albumin in order to be transported around the body. So albumin, very, very big, very important protein within the bloodstream produced by the liver. It does not cross the glomerular basement membrane. It's far too big usually. However, in nephrotic syndrome, albumin is going to cross the glomerular basement membrane because of some disease process, and as I say, we'll come on to which diseases can cause this later. Some disease process has damaged the glomerular basement membrane so badly that now albumin can cross the glomerular basement membrane. This leads to a classic syndrome. So, this is what nephrotic syndrome is. Firstly, it's going to lead to proteinuria, which means that you've got protein present within your urine, and that protein is quite simply the albumin that has been filtered into the glomerular filtrate, has made its way through the nephron, and is now present within the urine. So that's part of nephrotic syndrome. In addition, albumin within the bloodstream is going to become too low, so you're going to get hypoalbuminemia. Again, that makes complete sense, because you've lost albumin from the bloodstream through the kidneys. Now, what does hypoalbuminemia produce? It produces a phenomenon known as third spacing. So let me explain this. So you need to understand the basic concept of osmosis and water potential and osmotic pressure in order to understand this. So, this is a concept from A-level biology, that sort of level biology, that water has a osmotic pressure, and this osmotic pressure is all to do with how much solute is present dissolved within that solution, within that fluid. If you have two different fluid compartments that have different osmotic pressures because they have different amounts of things dissolved in them, then water will move from the compartment that has less dissolved in it to the compartment that has more dissolved in it. Now, albumin is one of the key things that is within the blood and holds water in the blood. It's one of the key things that's dissolved in the blood and maintains the osmotic pressure of the blood. It keeps the water potential of the blood low and stops fluid moving out of the bloodstream at the capillaries and into the extracellular fluid. Now, if albumin level goes down, then the osmotic pressure of the blood goes down. The water potential of the blood goes up. Extracellular fluid still has the same amount of protein present within it. Its osmotic pressure remains the same. Its water potential remains the same. So that means that now fluid is going to move out of the bloodstream and into the extracellular fluid from an area of low osmotic pressure to an area of high osmotic pressure, or you could say from an area of high water potential to an area of low water potential. So by osmosis, you're now going to get movement of fluid out of the bloodstream and into the extracellular fluid. This is known as third spacing of fluid, and it again is going to lead to really horrendous peripheral edema. So we're not just talking about edema of the legs here. Classically in nephrotic syndrome, you get so much edema that it even affects your face. You get a really, really puffy face in nephrotic syndrome. So horrendous peripheral edema in third spacing due to nephrotic syndrome. And it's because the albumin within the bloodstream, as well as performing this role of carrying loads of different molecules around the bloodstream, it also is important in holding the water present within the bloodstream in the actual blood vessels, and from stopping it at the capillaries moving out of the bloodstream and into the extracellular fluid. So when albumin goes down, when you get hypoalbuminemia, you get third spacing, loss of fluid from the bloodstream and into the extracellular fluid. Of course, that's going to make you extremely thirsty because your blood volume's gone down, so you'll consume more fluid. That fluid will then also leave the blood stream and go into the peripheral tissue, so you'll just go round in a vicious cycle until you become more and more swollen with peripheral edema. So these are the classic three things of nephrotic syndrome: proteinuria, hypoalbuminemia, and third spacing. So nephrotic syndrome is a really useful diagnosis. It's a classical syndrome, a classical picture of what has happened, and it tells a story. Coming on then to nephritic syndrome, which I said right at the beginning is not a useful diagnosis. We make the diagnosis of nephrotic syndrome clinically. We do use this. This is used clinically. This is a clinically useful concept, a very clinically useful syndrome. Nephritic syndrome is an old concept that I do not think, and many people agree with me, is a useful concept. It's not useful in categorizing renal disease, and it's not useful as a clinical diagnosis either. But let me explain what nephritic syndrome used to mean, and indeed still does mean. And we will come back to it in several points in the video where I'll explain when it would be appropriate for you to describe someone as having nephritic syndrome, but I would advise you never to do that. So, nephritic syndrome then. Nephritic syndrome is again damage to the glomerular basement membrane, but this time such bad damage to the glomerular basement membrane. And again, we'll come back to diseases that can damage the glomerular basement membrane later. Glomerulonephritis, for those who know anything. Nephritic syndrome is such bad damage to the glomerular basement membrane that you get huge great holes in the glomerular basement membrane that actually allow full-blown red blood cells to leave the glomerular capillaries and enter the lumen of the Bowman's capsule, and you then end up with red blood cells going all the way through the nephrons and ending up in the urine. So nephritic syndrome is such bad damage to the glomerular basement membrane that you actually end up with hematuria. And that's what nephritic syndrome is. It's really glomerulonephritis, which are the conditions that are capable of damaging the glomerular basement membrane, but glomerulonephritis that is so bad that it leads to hematuria. That's what nephritic syndrome is. However, that's why it's not really that useful a concept, because it's not really a syndrome in the same way that nephrotic syndrome is a syndrome. It's just another way of saying glomerulonephritis that is so bad that the patient actually has hematuria. So that's why I would steer clear of it as a diagnosis, and indeed you never see people actually making this as a diagnosis clinically, at least not in the UK. And it's also not particularly useful as far as categorising kidney disease is concerned. So I've told you about it just because I feel like I have to tell you about it, but we're going to not really use it as a way of categorising kidney disease, and we're not going to use it as a clinical diagnosis really as well, because all it means is glomerulonephritis that is bad enough that it's caused hematuria. Occasionally, the one sort of context that you do hear the word nephritic used is you can describe a patient as nephritic, in which case you're saying that this patient has glomerulonephritis so bad that they are actually bleeding into their urine, that they have hematuria because of their glomerulonephritis. So occasionally you see this used as an adjective, nephritic, to mean hematuria in the context of glomerulonephritis. So I've told you about it. Let's sweep it under the carpet now, and on to my final useful category of kidney disease, but one that is informal because you would never make it as an actual diagnosis, which is renal hypoperfusion. So in renal hypoperfusion, a disease of the kidney, and we'll come on to what disease is later on, but a disease of the kidney leads to just too little blood flow to the kidneys, and we'll find out later that actually many diseases of the kidneys firstly lead to this picture of renal hypoperfusion prior to leading to the picture of chronic kidney disease. So many diseases that eventually cause chronic kidney disease, they initially cause this renal hypoperfusion syndrome, where initially the only problem is renal hypoperfusion. Gradually, when it goes on chronically, it leads to loss of nephrons and CKD, but initially the picture is this renal hypoperfusion syndrome. So, what is the problem then with the kidneys getting too little blood flow? Well, in this initial phase, the reduction in blood flow isn't too bad. So it's not bad enough that nephrons are actually dying and being replaced by scar tissue, and it's not bad enough that renal function is hugely affected, i.e. you might not be uremic, you might not have problems with hyperkalemia or acidosis or any of these things. The kidneys might actually be coping perfectly fine even though the amount of blood flow that they're getting is too low. However, the big manifestation that happens in this early stage is that the renin-angiotensin-aldosterone system becomes overactive. And this is why I wanted people to watch the video on the renin-angiotensin-aldosterone system and the ADH system prior to watching this video, so that you have an understanding of that system. So, just to go over it basically, this system is all about maintaining blood volume. It's a system that changes its activity depending on what is happening to blood volume, and the way in which it judges blood volume is by looking at how much blood flow the kidneys are getting, because the higher blood volume is, generally the higher cardiac output is and the higher renal perfusion is. The lower blood volume is, the lower cardiac output is, and the lower renal perfusion will be. That's the basic logic that underlies the renin-angiotensin-aldosterone system. So, if renal hypoperfusion is present, so if the kidneys are getting too little blood flow, the renin-angiotensin-aldosterone system becomes increased in activity, it becomes overactive, and what does this result in? It results in it raising blood volume, because if this system is overactive, it thinks the reason for that is that blood volume is too low. It does not contemplate the possibility that there is something wrong with the kidneys, that there is a disease of the kidneys that is resulting in renal hypoperfusion. It thinks if this system's overactive, blood volume is too low, and therefore it results in the increase in blood volume. In addition, you will know that the renin-angiotensin-aldosterone system doesn't just control blood volume, it also controls blood pressure. And the logic for this is that remember, this system responds to changes in blood volume, it becomes more active, it increases its activity above its basal level of activity when blood volume is too low. When blood volume is too low, that will reduce cardiac output. when cardiac output goes down, blood pressure will go down. So it makes sense for this system to not only influence the kidney's conservation of water to bring blood volume back up, but also to influence total peripheral resistance of the peripheral arterioles and change blood pressure so that we can maintain blood pressure at the normal level in the face of changes in blood volume and cardiac output. So actually, angiotensin II of the renin-angiotensin-aldosterone system also raises total peripheral resistance. It causes peripheral arterioles to constrict in order to maintain blood pressure in the face of a change in blood volume. So let me say that again. Remember, this system has a basal level of activity. It increases its level of activity above that basal level of activity in response to blood volume going down. Its targets are the kidneys in order to maintain the water, in order to tell the kidneys to conserve water to bring blood volume back up. But its targets are also peripheral arterioles, and it causes them to constrict to increase total peripheral resistance. And the reason it does that is because when blood volume goes down, that is going to decrease cardiac output and decrease blood pressure. So we need to increase total peripheral resistance if we're going to maintain blood pressure. So that is why this system both influences the kidney's conservation of water and also influences the peripheral arterioles and causes them to constrict and raise total peripheral resistance. Now, let's consider what happens then in the face of kidney disease. If we have kidney disease that is causing renal hypoperfusion, this system is going to become overactive. Its activity is above basal level, and therefore it's going to raise blood volume and also raise blood pressure. Raising blood volume is also actually going to lead to a rise in blood pressure secondarily as well, because it's going to raise cardiac output. So both of these things, both the direct effect of angiotensin II on peripheral arterioles and the increase in blood volume that is driven by aldosterone, they're going to lead to blood pressure going up, and that's the key thing in this renal hypoperfusion syndrome, that you end up with hypertension, and this would be secondary hypertension rather than primary or essential or idiopathic hypertension. This is hypertension because of an underlying disease of the kidney that is leading to renal hypoperfusion. Now, what then are the symptoms of hypertension? Well, usually hypertension is a silent disease. However, if blood pressure becomes very, very high, what it can result in is headaches. It can result in pounding, generalized headaches that are due to too much blood flow going through the blood vessels that are in the meninges, the meningeal blood vessels, and also the blood vessels that are in the subarachnoid space, the extracerebral blood vessels. So too much blood going through those can activate pain receptors up there and lead to a generalized pounding headache. So there is renal hypoperfusion, the final category of kidney disease that I wanted to discuss, and it's going to result in overactivation of this renin-angiotensin-aldosterone system and therefore secondary hypertension, the major symptom of which can be a generalized pounding headache that goes on and on and on and on. Okay, so we will have a break there, and in the next video what we'll talk then about is different causes of all of these 4 different categories of kidney disease, and we'll start with acute kidney injury.